Ladies and gentlemen, you're welcome to this bi-monthly webinar on female health education. My name is Dr. Lucy Mahapa. I'm a urogynecologist here in Polokwane. Today we're going to discuss a very important topic that afflicts majority of women, usually women in the sexually active women. The presentation of today is about a condition called pelvic inflammatory disease. Pelvic inflammatory disease is a condition that affects young, middle-aged, and sometimes the elderly. And we're going to discuss the causes, the pathogenesis, the management, and how we can avoid this. It's an avoidable condition. We will go through this together, and thereafter we'll have some discussion together. What is pelvic inflammatory disease actually? It's a spectrum of infection and inflammation of the upper genital tract. What do I mean when I say upper genital tract? It's an infection and inflammation of the genital tract above the level of internal cervical os. You know, a cervix has got external os and internal os. If infection and inflammation is above the level of the internal os, that's pelvic inflammatory disease. If it's below the level, that level, it doesn't fit into the definition of pelvic inflammatory disease. It typically involves the structures above the level of the cervical internal os, which involve the uterus. If it involves only the uterus, it usually affects the endometrium. Endometrium is that part of the uterus, that layer that a woman bleeds every month if she's still in the reproductive age, still menstruating. And it can extend further to affect the fallopian tubes. And if it spills, the infection spills out of the fallopian tubes, to find the nearby organ is the ovary. It can affect the ovaries, and it can also spill into the peritoneum of the pelvis and surrounding structures called pelvic peritonitis. Let's explain it this way. If we've got a cervix, and this is a drawing of a uterus, there's an external os and internal os. The whole thing is a cervical canal. From internal os upwards, if infection is there, it constitutes what we call pelvic inflammatory disease. It can affect the endometrium here and spread through the tube, the ovaries, and the pelvic peritoneum. Like in here, if you see the picture here, on the left side is a normal, uninfected uterus with a tube which is thin, with an ovary which is not inflamed. But if the organisms, the bacteria, enters the uterus above the level of internal os, it causes inflammation of the endometrium, which is called endometritis. And if it spreads further to the tube, it causes what you call salpingitis. In the tube, the bad thing about it can even cause an abscess there, causing a tubal abscess, but it can spill through the tubal ostium to affect the ovary and the parametrium. Parametrium is that peritoneum that lines the structure inside the pelvis and the abdomen. Like you see, if it spills here, it will show the parametrium, it will affect them. That's why it becomes severely painful. The condition comes because of the ascent of or spread of organisms, which mostly are bacteria, from the vagina through the cervix upwards into the uterus and the fallopian tube, and ultimately into the pelvis. Usually, this, if they're all affected, that's why I say it's a spectrum of disease. It might affect one region, or it might affect many regions. If it affects one region, say it affects it can affect the uterus, the tube, the ovary, or the peritoneum. The exact site of infection, usually clinically, you cannot say this is affect only the uterus, this affect only the tube. It only can be found through laparoscopy. You scope the patient and see which area is affected. But majority, you find that more than one area is affected. So the term PID is a term that does not denote the site of infection. The term PID should not be used if it below the level of internal cervical os. it should not be used. If they have got inflammation of the vulva, the vagina, or the cervix, it's not part of the PID. If it affects only the uterus, we call it endometritis, because it's the endometrium that is affected, that's inflamed. If it affects only the tube, the tube is salpinx, it's called salpingitis, which at laparoscopy you can be able to diagnose the site of infection. If it's the ovary only affected, it's called ovaриtis, because it affects only the ovary. If it affects the pelvic peritoneum, we call it peritonitis, severe pelvic peritonitis. The cervix, I must say, is not included in the list of PIDs. So if it affects the cervix, it's not a PID. Let me start with the conditions that affect female genital that are not part of PID. Vaginitis, vaginal discharge, vaginal inflammation, vaginal infection is not part of PID. The vulva is not part of PID. If you've got vulvitis, which usually vulval infection usually coexists with vaginal infection called vulvovaginitis, which is inflammation of the vagina and the vulva. This does not form part of PID. And it's got the typical symptoms. You might find itching at the vulva, burning, and sometimes pain during sexual intercourse, but it's not part of PID. And the main cause of infection of those lower genital tract infection usually caused by bacterial vaginosis, bacteria that called bacterial vaginosis. I must explain. Vaginosis is not vaginitis, because in vaginosis, there's no inflammation, but there's infestation with bacteria. Most especially the anaerobic bacteria like Bacteroides, they usually stay there and cause vaginosis. And yeast infection, the Candida, they don't cause much inflammation, but they stay there, and then they hardly cause accent through the cervix and cause PID. The Trichomonas, which are the protozoans, they usually just cause irritative pain, greenish, foamy vaginal discharge, sometimes with not good smelling, but it does not cause PID. And sometimes allergies, some people are allergies to soaps, some are allergies to spermicides. Some, after menopause with reduced estrogen level, we usually call vulvovaginitis. That's not part of PID, what we're going to discuss today. Today we'll discuss PID side by side. Let's start it. Endometritis, inflammation of the endometrium. If the bacteria above the level of cervical internal os infest the uterus, it will infect the layer that the woman bleeds every month during menstruation and make it thicker. And it causes intermenstrual bleeding. In between the months, before she expects that she'll be menstruating, she will be bleeding, which is just spotting because of inflammation of the endometrium. That's called endometritis. Salpingitis, I said, is when the fallopian tubes are inflamed, are infected, and are inflamed. It's infection and inflammation of the fallopian tube, which symptoms, they are not specific because those symptoms may exist with ovaриtis and pelvic peritonitis. Firstly, you'll have abnormal smell, vaginal discharge, abnormal smell from the vagina. And during ovulation, there might be pain because when the egg comes out, most especially if there's ovaриtis, you will get pain. But this pain must be differentiated from what you call ovulation pain, which is called middle smash, which is slight pain which doesn't last many hours. This one lasts many hours. And the worst is painful during intercourse, because during intercourse, the tube is being shaken by whatever is inside the vagina, shaking the tube, and thus causing pain and exacerbating that inflammation and swelling. And some women will present with dull lower abdominal pain, or it might radiate to the back. Because these are bacterial infection, they are always accompanied by raising temperature, fever. A woman will always have fever. And because it affects also the intestines and the peristalsis, she might feel nauseous and bloated, and sometimes she can even be vomit. That's why when you come to other differential diagnosis, you see that PID needs to be diagnosed precisely, excluding other dangerous conditions like appendicitis, because appendix infection also present with vomiting. Many people miss appendix, say that it is because of this PID, while it's not PID. But if it affects the tube, the commonest thing that it does, because the tube has got other relations next to it, other organs that are next to it, which are the ovaries and the intestine. And on the right side, we've got appendix. You might find that those inflamed structures, they get adherent to one another, causing adhesions. And one of the management of those adhesions is just to lyse those adhesions and remove them, because a tube, which if we see a normal tube is thin, is not thicker like this. An inflamed tube becomes thicker and swollen. And if a tube is swollen, it's prone to have adhesions on it. The tube on my left side is normal, on the right side is swollen. And if it's swollen, it tends to cause what we call febrile phimosis. It closes at the end there, that the exudative fluid that's caused by inflammation, it accumulates here and causes water inside the tube, which is a condition called hydrosalpinx. Hydrosalpinx means nothing but water inside the tube. Such tube will not be able to conceive. The other section is oophorytis, inflammation of the ovaries. Symptoms more or less similar like salpingitis, with abdominal pain, pelvic pain, or vaginal discharge, which is foul smelling also. Dyspareunia is the commonest thing that will bring the patient to consultation. Dyspareunia means painful sex. Painful sex is the commonest thing that will bring the patient to consultation. What is good about pelvic dyspareunia, or bad about dyspareunia, is that it is such a debilitating condition that it disturbs the harmony inside the bedroom. But some men, I will always consult people coming with dyspareunia. Women complain that they don't get sympathy from their partners, because once the woman has got dyspareunia, which is deep dyspareunia, people sex, more especially a deep penetration, the man doesn't regard that as a serious condition. Actually, she gets glorified. She thinks it's because she's so good, she makes people cry. It means he is a man enough to can make people cry. Well, actually, dyspareunia is not something that should be there inside any bedroom. Of course, because it's bacterial infection, we have fever and chills, sometimes vomiting. You see, the signs are the same as that of salpingitis. Will be oophorytis with inflammation of the ovary, which the ovary will be swollen, bigger than the other ovary. If it's worse, it's spread up to the inflammation of the peritoneum, which is the inner wall of the abdomen that covers all other organs in the pelvis and in the abdomen. There will be diffuse abdominal rigidity. Abdominal pain will go up to the umbilicus or even above the umbilicus. And if you touch that patient, she will guard. She will not allow you to touch it. It will be abdominal guarding. Sometimes if you touch it and leave it, the patient can jump. That's what you call Bloomberg sign or rebound tenderness, especially if it's generalized, because the boundary between the abdomen and the pelvis, there's no boundary. So once it's in the pelvis, can spread up into the abdomen. And the fever will be very high, more than 38 degrees Celsius. Because it also involves the intestines. Then you're going to have intestines that are inflamed and they get paralyzed. You get what you call paralytic ileus. With paralytic ileus, you might get the signs and symptoms of subacute intestinal obstruction. While it's not obstruction, it's just ileus, which will cause nausea and vomiting because there's no peristalsis and movement of food from the mouth towards the anus, and thus the abdomen will be bloated and thicker. Because with the passage of food downwards, we won't be able to pass the gas, there won't be flaters, there won't be able, little bowel sounds. Bowel sounds will be diminished. And usually with peritonitis, if a patient comes with peritonitis, usually I admit the patient. And yeah, if I have to have a chance to do laparoscopy and diagnose general peritonitis, I find it very easy if after testing how much damage it has done to the tube, because once you have got a chance of doing laparoscopy, examine the tubes so that she's going to ask you, what are the chances that I'm going to have a baby? So that you can have something to tell them. Somebody didn't mute. Please, everybody mute yourself. Somebody's talking there.
All right, then I will bet to work. I don't work in mine.
Okay. Let me look for him. Esok Mosa, please mute. Then what I do, I usually do a pelvic lavage. Usually not through the abdominal, through the pouch of Douglas. You can wash that with fluid which has got antibiotics inside. It tends to hasten it clears the infection. The period of infection become reduced if you lavage with antibiotic saline in there and you suck it out, because that will be direct application of antibiotic at the site of infection and inflammation. That helps a lot. What is the epidemiology of pelvic inflammatory disease? Actually, the exact incidence of PID, we don't know it. It may differ from region to region. But one thing sure, it's on the rise. It's rising up. Why is it on the rise? Because of the rise in the incidence of sexually transmitted infection, usually bacterial infection, not viral infection. Bacterial sexually transmitted infection are on the rise. And because these days, there's a lot of diseases that requires antibiotics. Most women have had some antibiotics for other illness or another. So you find resistance to antibiotic is very high, more especially the newer antibiotics that are not much, there's no much resistance to it. They work very well for PID and other sexually transmitted infection and even other infections which are not sexually transmitted. People tend to use them. That's why in antibiotic stewardship, we say you must spare the newer antibiotics for serious infection. But of course, every GP wants to be the best GP, wants to treat the patient, and within 2 days, the patient is well, is going to talk good about you. And that these are used. When the quinolone came in, they were very good in PID and STI. They were abused. Now they are developing resistance towards them. The penicillin, there's so much resistance towards them. If we abuse antibiotics, we may end up having no good antibiotic to treat by the time we've got serious infection. One of the things that makes PID so prevalent is poverty. Poverty, not affording treatment. People have got PID, they can't afford treatment, or health services are poor. Then they've got PID which damage their organs irreversibly and present with infertility. And I remember when Thabo Mbeki said HIV is caused by poverty, people didn't understand it. It doesn't mean that it's a causative agent. It means, as I say, that poor people don't access healthcare services. So if they've got PID, it becomes worse untreated. And of course, our health system, because as I've said, that antibiotic resistance is very high, you might find that most in the public sector, the type of antibiotics that are on the shelf there, and majority of the antibiotics, which are older antibiotics, which we have got much resistance towards them, and prescription is just liberal and causing more resistance to antibiotics. One of the things that's common, which is a South African thing, I haven't been to other areas in Africa, but I think South Africa, I've been here since I was born, is commercialization of sex. Commercialization of sex increases the incidence of pelvic inflammatory disease. How? Because with commercial sex, the female partner has got no much choice. She can't decide, I want condom, I don't want condom, because she needs the money. And with commercialization of sex and poverty mixed together, poverty, if it's there, sex will be poverty. Majority of women go into unprotected sex because of their poor status. If you can address poverty, we'll reduce commercialization of sex and empower women. The incidence of PID, they say in the literature ranges between 2 to 4% of sexually active women. I think they're referring to the European there. I would say without proper figures in South Africa, 10 to 20% of sexually active women have got pelvic inflammatory disease. From my practice, I think 20 to 25% of people who come with pelvic infection are PIDs. And it accounts more than 60% or more of infertility cases. Most of infertility is caused by pelvic inflammatory disease. The rest is other rare things that cause infertility. The tubal blockage, ovarian blockage, anovulation caused by pelvic inflammatory disease is a lot. And the other thing that makes it so prevalent, and that's why in my opening statement I said it affects the young, the middle age, and the old, but the young a lot. the teen ill-discipline. The teenagers' ill-discipline leads to unprotected sex, irresponsible sex, that leads to overt infections and blocked tube while teens and cause infertility while young. Why teens are ill-disciplined these days? It's because I think it's a government thing. It's a pro-1994 things. They legislated child rearing. Child rearing, you can't legislate it. It's an instinct. Every animal, when it makes a child, it knows how to rear it. I've seen a dog. A dog knows how to raise a puppy. A hen knows how to raise a chicken. Every animal will raise a chicken. If Africans can be allowed to raise their chickens the way Africans raise their children, there wouldn't be teen ill-discipline. During our age, there was no such teen ill-discipline. We'll go and play with girls, and we never think about sexual intercourse. Nowadays, if you move around in the villages, you find that in the bushes, far from town, you find girls coming from school and boys hugging each other. You find girls and boys hugging like this. At this age group, there's no time for romance. You can't romance at this age group. And if you look at this picture, the girl seems to be older than the boy. This is what leads to the rise in pelvic inflammatory disease. And as I said, 90% of PID are due to sexually transmitted infection in sexually active females, which means below menopause. Of course, this STI is not the only cause of PID. About 10% or less can be caused by procedures like endometrial biopsy if it's not done under sterile condition. Procedures like hysterosalpingography can introduce the bacteria from the vagina deep into the pelvis, right up into the fallopian tube. Insertion of a loop, intrauterine contraceptive device, can also take bacteria out of that if it's not done, the vagina is not well cleaned before it's inserted. One of the things that makes PID prevalent is after legalization of abortion. After legalization of abortion, we found that people don't go to theater to do what you call dilatation and curettage, which used to be done previously under general anesthesia. They've developed what you call manual vacuum aspiration. That's an unsterile condition, and it doesn't completely remove the product of conception. So after manual vacuum aspiration, you still have residual products of pregnancy inside there, which undergo subclinical inflammation and which makes another as a good fertile soil, a good culture medium for subclinical infection to occur. So with the advent of termination of pregnancy, we see PID more often, which mostly is subclinical. Patient is not even aware that she had PID, but she presents later with pelvic inflammatory disease. And this PID causes a lot of morbidity in women of childbearing age. One of the morbidity is infertility. So a lot need to be done with us to reduce the prevalence of complication by raising awareness from these diseases. The reduction in the number of or the incidence of unwanted pregnancy will definitely reduce the number of termination of pregnancy, and that's the number of manual vacuum aspiration, and that's the number of people suffering from PID, other clinical or subclinical. The intrauterine contraceptive devices, the copper laden one, the one that has got copper inside, the other copper T or other, they are not supposed to be given. That's why they are not supposed to be given for a woman who has not had children. Why? I see nowadays you find that a schoolgirl come and say, I've got a loop. Where do you get it? She said, I was given it by the doctor. Even the clinic gives that. Do not give a loop to a woman who doesn't have children. Why? Because a loop, the mechanism by which it prevents pregnancy is by reduction in temperature and causing subclinical inflammation around the endometrium. It causes subclinical endometritis. And it's a fertile soil it's a culture medium by itself. It's a fertile soil for bacteria to multiply around this copper. So if a woman can have infection, which ascend very easily through the strings that are inside the vagina, if the infection ascend there, then you're going to have a situation where a woman is going to have a subclinical pelvic inflammatory disease, and with subclinical inflammatory disease, he might have tubal blockage. And loop must only be given to a woman who is either finished childbearing, or if she can have the tubal damage from subclinical PID, she will not worry because she has got other children. Teenagers, this is not a contraceptive for teenagers, but we see it being done. And for the doctors here, please don't give an intrauterine contraceptive device to nulliparous women who don't have children, especially the teens. Don't give that. Another thing, in the epidemiology, children only send them to school, we send them to go and learn. You move around, you see after school, instead of discussing homework and other things, you find women like this. These are one of the risk factors. Children go to school, they don't learn school things, they learn wrong things, they get long results because teens are sexually active. Sexually active teens are dangerous to themselves, not to the society. Multiple sexual partners. It doesn't matter whether it's in teens or in adults. This multiple sexual partner is becoming epidemic. Even in outside marriage and inside marriage, there are always multiple sexual partners. I don't know why. The community, the morals have gone down. Ideally one person should have one partner, but it's understood that 1 out of 5 couples in South Africa, one of them is a cheater. Either a man or a woman is a cheater. You can't say more cheaters are men, more cheaters are women. There's so much infidelity such that PID, if it occurs in a relationship where there's multiple sexual partners, it means once one partner will have, it's likely to infect 2 or 3 other people. So the incident rise. And absence of use of condom. Condom is a barrier method of contraception. So if used, it will block infection, it will block also pregnancy. If in multiple sexual partner there was use of condom, there wouldn't be much PID. A person with previous history of pelvic inflammatory disease, which means he's exposed to other risk factors, is that he's got multiple sexual partner or he doesn't use protective measures, is likely to have another PID. The intrauterine contraceptive users, I have stressed that it should not be used in people who don't have children because they themselves, they make PID worse. If you've got PID, they don't cause PID. I'm saying if infection happen in the presence of intrauterine contraceptive device, it becomes fulminant. Bacteria multiply faster in the presence of IUCD because it's a foreign body. Commercial sex, we can't stress it. But what is commercial sex actually? I tried to look for the term for this. I can't find it. And I think when I look at it, I think it's another term for prostitution, which is an act of exchanging sexual services for money or other compensation. You say, you have sex with me, you give me so much. In South Africa, it's glorified. It's also called sexual services. But what's your job? I'm offering sexual services. I'm a sex worker. They call a person a sex worker. I've never seen an advert where they've advertised where they want sex workers and then they want good sex workers. But they say there are people who are called sex workers, and this name is glorified and romanticized, which is nothing else but prostitution. We should not glorify it and sugarcoat it. You know, when we grew up, when we were young, the elderly, if somebody is having unwanted sexual relation, they call them by the names that nobody wants to be called about that name. I think we should just call it prostitution. Commercial sex worker, it's nothing else. And then if somebody is providing sex service in exchange of money and other things, it's fair. Then nobody will like to be fair. But if you glorify it, yeah, it will have a title. It will have, and it's got a title here. There was this story that I don't know whether it's true or not. There was some times back they said the parliament is going to move to Midrand, and they say the commercial sex workers in the Cape were picketing and say, hey, we make money when the parliament is seated. So it means that if we don't start there at the head, we're not going to treat PID very well. And so commercial sex, by definition, is any sexual act performed in the exchange of something of value, whether money or drug, transportation, any favor that a woman engage with a man in exchange of that something, that sex is commercial. And it's there from teens up to adulthood, inside and outside marriage. What can protect PID? Protective factors. The single most important thing that can protect people from having PID is monogamy, monogamous relationship. Only one partner from both sides. It mustn't be one partner from one side. Because monogamy is a form of relationship where a person commits to having a single partner or a single romantic relationship. In this type of relationship, both partners must maintain fidelity and loyalty to one another. They must totally forgo romantic relationship with the third party. It is common in many cultures, this monogamy, especially European and white cultures. Infidelity is a reason for divorce. But in infidelity, we just fight about it and we go on. We have accepted it. So even the new constitution of South Africa, it allows infidelity. If it allows polygamy, it allows infidelity, because you can't marry the second wife without falling in love with him first, which means when you see a person going polygamous marriage, she started as infidelity. So infidelity in South Africa is constitutionalized, so which is a fatal soul of PID. I think the reverends must do a lot to preach fidelity, because constitution, it says you can marry more than one wife. And once you go to marriage, there must be courtship, which means you can have courtship while you are married and have courtship with another woman. One other thing, which not difficult to have, but not always practical, most especially within marriage, is abstinence, celibacy. If you abstain from sex, chances of you having PID are less. You might have PID from other causes, which I said will cost 10%, but PID rate will go down. And the use of barrier methods of contraceptions are really very important if you know that your sexual habits are not that one can talk about in front of people. You've got bad sexual habits. Use a condom. Use a condom. There are male condoms which are readily available, easy to use, and both men and female can have them. And then during sex and say, let's use this. Or a woman can wear a femidom, a female condom, which she always wear if she's that ever-ready woman. And then there'll be a barrier between the man and the woman, and PID will be less. What causes PID? The microbiology. It is said to be a polymicrobial disease. Polymicrobial means many microbes cause it, many microorganisms cause it. It's not only one cause. In fact, that the person has got about 3 or 4 microorganisms in the same person, catching the same person with PID. Because it's caused by many organisms which ascend from the lower genital tract upwards from the vagina, the cervix, the uterus, the tube, and get out into the peritoneum. The primary organism are those organisms that are sexually transmitted, which are called sexually transmitted infection. Just to mention few, these are not all sexually transmitted infection. This is gonococcal, Neisseria gonorrhoeae. This is a diplococci. These are chlamydias. The chlamydia, the Mycoplasma, Gardnerella vaginalis, and Ureaplasma are the ones that are not much commonly, but the commonest cause is Neisseria gonorrhoeae, which causes gonorrhea, and Chlamydia trachomatis. And unfortunately, Gonorrhea in female, it doesn't show very well clinically. It might cause mild vaginal discharge, which is not foul smelling. Even chlamydia trachomatis, it might cause just mild itchiness. But in males, it causes clear symptoms. Gonorrhea will cause pus coming out of the penis on urination. Because urine is acidic, it will be very painful during urination. The same as chlamydia trachomatis, which can also cause a non-goccal urethritis, which cause painful burning and micturition. In women, the only thing that he can complain about is dullness and pain in the region of the pubis and the pain deep inside, which might radiate to the back. That's what gonorrhea and chlamydia can cause. Other organisms that usually they do not cause PID if they are alone. But if they super infect, they find that the person has got primary organisms that cause PID, like these organisms, and they go there as secondary invaders, they exacerbate the disease. These are anaerobic organisms, like this gram-positive organism like Staphylococcus, which is a normal commensals of the skins and everywhere, whether hemolytic or non-hemolytic, and anaerobic organism like Bacteroides species, Bovius and Fragilis, and Peptococci. They themselves, they won't cause pelvic inflammatory disease. Bacteroides fragilis will cause bacterial vaginosis, which I said is not vaginitis. But if they infest an area which already have pelvic inflammatory disease, be sure that it will be very difficult to control that. Because it means these organisms are not pathogenic on the lower genital tract, but become pathogenic as secondary invaders of the upper genital tract. If alone they are asymptomatic, they can cause vaginosis, but become a secondary pathogen organism in the upper genital tract to make PID worse. If they are on the like Bacteroides and species, I said they cause bacterial vaginosis, which can be diagnosed by two. I must tell about, because most women have got bacterial vaginosis, but they are not aware because it's not painful. It's diagnosed by the presence of at least 3 out of 4 criteria, which is called Amstel's criteria, which is homogeneous vaginal discharge, whitish vaginal discharge, which is fluid and homogeneous. Vaginal pH, which is raised above 4.5. That such women are prone to have candida because the pH now is acidic. A positive whiff test. Whiff test means a fishy smell after adding potassium hydroxide on the discharge. This, you can test it without potassium hydroxide. Potassium hydroxide is an alkali. Sperms are alkaline. Semen is alkaline. If after depositing a semen inside the vagina with bacterial vaginosis, there's always a fishy smell inside the house. If you find a fishy smell after sex, after depositing semen, you must know the woman is being infected with other Bacteroides species or Peptococci species, which is the causative agents of bacterial vaginosis. And you need treatment. That's the only way you can find, because in itself is not painful, but it can exacerbate PID. It doesn't cause PID. And if you look under the microscope of the cells, if you examine, you'll find something through cells. So a fishy smell after sex is BV, it's bacterial vaginosis. The mode of infection of PID. What is the mode of infection of PID? How do we get infected with PID? The mode of infection, the organism ascend from the vagina through the cervix, the uterus, the fallopian tubes, and go and cause generalized peritonitis. What facilitates this? There must be a carrier. Usually, sexually transmitted vectors are the facilitators. And one of the vectors that carries the bacteria up there are the spermatozoa. After sex, the sperm swims through the cervix and carry along the bacteria that they found in the vagina to the site of fertilization and cause PID. That's why we say it's a sexually transmitted infection. An infection like trichomonas, which I said is usually a vaginal pathogen which doesn't cause PID. Because they are protozoas, these trichomonas, it's got undulating membranes and flagellates and flagella, they can carry out other organisms like gonorrhea and go and plant them up in the endometrium, in the tube, and even in the pelvic peritoneum. During menstruation, there's a phenomenon which is called retrograde menstruation. When the blood is supposed to come out through the vagina, some of the blood goes back towards the tube and is going to bleed inside. If there's endometritis, that will spread the PID into the pelvic peritoneum. Some organisms like Mycoplasma can just go be transported through the parametrium, through the lymphatic system, which drains the lymph out of the uterus and drain to the far sides, but bacteria don't do that. Mycoplasma do that. They spread through the lymphatic. Let's see a picture of sperms deposited in the vagina. As they swim inside here to go and search for fertilization in the tube, if there are infections inside the vagina, the sperms will carry that infection. The same, menstruation should come from the uterus downwards. But if there is backward menstruation, retrograde menstruation, in the presence of endometrial inflammation and infection, it will carry that bacteria down there, and that causing and spreading pelvic inflammatory disease. That's why I say sperms are the carriers. But sperms in a healthy environment, they don't. And it doesn't always mean that when sperms carry the organism, they find the organism in the vagina. The organism usually comes with the sperm. Sorry. A condition called gonococcal urethritis, which is inflammation with Neisseria gonorrhea. It used to be called drop. Some people call it Schoffel. If infected, the sperms with this pus substance coming out of the penis is injected into the vagina, that will cause PID, like it or not. And in the women, she will be lucky if she presents with vaginal discharge. Some women don't even present with vaginal discharge. The first thing that you see is overt PID. If it has discharge, it will be so subclinical that it doesn't even stain the panty. So, and she's not aware that somebody with purulent penile discharge of gonorrhea has injected this inside the body, and she's going to have pelvic inflammatory disease some weeks thereafter, not now, some weeks thereafter. This is why in a relationship where a person has got multiple sexual partners, you won't even know which partner infected you. I always advise, even inside or outside marriage, that men should look at their women once or a while. Just examine the partner's penis. Say, terrible. Let's examine. Maybe there's pus there or something, because you don't never look what's going inside your body. The gonorrhea is on the rise and is the commonest cause of vaginal discharge and pelvic inflammatory disease. How does it cause that? Pathogenesis. The insults start at the endometrium, as is the nearest. And when it goes to the tube has got lots of folds and rugae and the lumen. It damages the folds and the lumen and the ciliary action of the tube. So the tube cannot transport the egg any longer. The endometrium, it causes intermenstrual bleeding. And if it's in the tube, always it's unlikely to be unilateral. Both tubes get affected. It will be a lucky woman who the other tube gets affected more than the other, but usually tubal involvement is always bilateral. And the progress to blockage of the ostium of the tube and accumulation of exudative fluid inside the tube, causing hydrosalpinx and endosalpinx. This destruction in tubal epithelium makes the tube just to be like a pipe which cannot propel the egg from the femoral end into the uterus after fertilization. That increases the chance of the egg implanting in the tube, thus causing ectopic pregnancy because of damage to those cilia, the hairs that will sweep the egg from the ampullary end of the tube to the ischial end of the tube. And those microvilli are damaged by this and the tube becomes edematous and hyperemic infection and thick that they lack that peristaltic movement, and they adhere to the nearby organs like omentum and ovary and appendix and etc. And those adhesions are one that are going to contribute to deep dyspareunia. In the severe cases, all organs in the pelvis might adhere to one another, resulting in what we call frozen pelvis. You open the pelvis, there's no way you can separate one organ from another one because of severe infection. This causes irreversible damage to the tube and causes chronic pelvic pain and infertility, which is not treatable by any surgical means if the tubes are damaged. The one thing that we worry about in PID, besides the pain and the other sequelae, is damage to the fallopian tube. Damage to the fallopian tube means infertility until proven otherwise. So if one ever got the opportunity to do laparoscopy, all what you meet in a patient with PID is adhesions. In this woman, when I entered, it was adhesions adherent of the intestine with the anterior abdominal wall, which I'm cutting here. And then when going back to the ovaries and the uterus, you find more and more adhesions. As you go down, you find that the tube, the omentum is adherent to the tube, that blocking the tube, making the patient infertile. The omentum is adherent to the parametrium. The omentum is adherent to the ovary, that the movement of the egg from the ovary to the tube becomes impossible. And if the tube is blocked, it contains fluid inside. It makes a ball, that's hydrosalpinx, with fluid inside. And that fluid inside here, you see, is dark greenish, which means it's potentially infected. This woman might just develop a pelvic abscess. And a hydrosalpinx like this is not amenable to surgical treatment. The only thing that you can do to it is just to cut it and remove it and cut the tube. And that's why when a woman has got a PID and you take her for fertility assessment or assessment of fertility, tell her that if I find the tube irreversibly damaged, I'm going to remove them. Because if you remove them without telling her, she's going to blame you for removing a tube while she still wants a baby. While on the other hand, she didn't have a tube that could have a baby at all. That tube is so severely damaged that it can't have any baby. Another way PID is so bad is that if it adheres other structures like appendix on the right here, and you don't separate from the appendix, should the woman suffer from appendix infection, which is appendicitis, it becomes very difficult to treat that appendicitis. And if appendix burst, it might burst inside the tube and inside the uterus. The woman might end up, in order to treat appendix alone, you might have to remove the uterus and the adnexum, all of them, because they've been adherent to one another before appendicitis. So whenever I find appendix adherent to the tube, remove it before it becomes appendicitis, because we can now predict which patient will have appendicitis. And of importance is that the patient should be warned of possible modality of treatment should the results be such that the prospect of fertility with the degree of damage that is be done by pelvic inflammatory disease are nil. And then you can remove that tube, because if you don't remove it, as time goes on, it might burst, it might cause pelvic peritonitis, might cause pelvic abscess, might even kill the patient. So it's important that if whenever there is a hydrosalpinx like this, the patient is forewarned, because we are living in the era of human rights. Every woman has got the right to know what's going to happen with her. If you remove something without warning her, she might come and blame you and say, you removed my tube without my consent. I would have used that tube to conceive. But in essence, a tube like that will never have a baby. You can never have a baby with a tube like that one. A tube like that one, you must just cut it and remove it and show the patient that it was so severely inflamed. If we send to the laboratory, then she remains without a tube. And without a tube, the only method of conception that she can have is IVF, which is not cheap. Not every woman can afford to have in vitro fertilization. Of course, even if with that tube there, if it was there, she was still going to have IVF as a mode of fertility because that tube would never help. What is the pathology? In pelvic inflammatory disease, exfoliated cells along inside the tubes, they produce a watery fluid, which is called exudate, which can either be poured out at the tubal ostium and irritate the peritoneum, cause pelvic peritonitis, or it causes febrile tubal blockage, either firstly by agglutination of the fimbriae and phimosis of the fimbriae, and later total tubal blockage, and cause what you call hydrosalpinx. Hydrosalpinx is means water in the tube. And the usually closure of the ostium is bilateral, both on the uterine side and on the fimbrial side. It closes and causes water in the tube. And you find that the tube now starts to swell with water inside it, which is called hydrosalpinx. This is typical fallopian tube with water inside it because it's blocked on the both sides. And this hydrosalpinx gradually damages the tube, damages the cilia, damages the mucosa, and that tube just becomes a pipe, which is so thin. And the only thing you can do with such a tube, hydrosalpinx, is to remove it. Why you remove it? For two reasons. I said you avoid superinfection to cause pelvic abscess. Also that if you do IVF with hydrosalpinx, the fluid inside the hydrosalpinx, it is said it can retrogradely go back inside the uterus and causes early miscarriages. So in IVF cycles, if there's hydrosalpinx, it must. Yeah.
We hear you.
Okay, now I must go. That's the thing. I don't see my thing now.
You should go to where you're dealing with the hydrosalpinx that can go into the uterus and cause early miscarriage.
Yeah, I want to go there. I want to go there.
Yeah. Okay.
I want to go there, but I've lost it here. I'll get it. Don't worry. I'll get it. Yes. Like I said, I don't want disconnected this thing. You know, I'm going to present it here. What is here? It's not here. Okay, let me share it here. Share it. Share it. Are we together now?
Yes, we are.
Yes, doctor.
Yeah, I'm running to where I was. I'm sorry. I'm sure I'm the one who made this mistake because as I was pointing with my pointer, I must have pointed something that made us disconnect because I just saw a second Zoom coming in. So I'm going back to that slide where I was talking about what Soli was talking about. I was talking about, I said depending on the virulence of the organism, the exudate in the tubes might either be watery, that producing hydrosalpinx or fluid in the pouch of Douglas, or it might be infected with bacteria and cause a pus, purulent, Purulent exudate means purulent, either causing biosalpinx. Biosalpinx means pus in the tube or pelvic abscess. Which is a medical emergency. Because purulent exudate changes the pelvic environment altogether and favors growth of other microorganisms, even those that would not necessarily cause PID, resulting in deeper penetration into the tissue and more tissue destruction. That's what it leads to pelvic frozen pelvis. There will be adhesion of the fallopian tube to other pelvic structures, being intestine, the ovaries, the appendix, as we've seen in the other picture. And because adhesions are not well supplied with blood, there's poor antibiotic penetration and that poor response to treatment that leading to chronic pelvic pain. And sometimes if it's been for a long time or the infection was so severe, it might lead to irreversible tubal damage, thus causing infertility. And such patients with irreversible tubal damage can only be helped by artificial reproductive technology, like IVF, which are not easily accessible and are not cheap. And sometimes when you examine bimanually, there are nodules in the pouch of Douglas, most especially in the presence of frozen pelvis. And those nodules inside the pouch of Douglas are because of the adhesions in there. If you go laparoscopically, you see a tube which is inflamed with the fluid which is watery there, which is sanguinous there, serous fluid there. And this is fallopian tube that I'm holding, but there is omentum adherent to it there. You know, omentum it adheres to any structure. It's a masquerade of anything. Whenever there's a damage inside the pelvis, omentum will go and adhere there. That's how it causes infertility. And if you've got nodules, the nodules can be so hard that they even cause dyspareunia. And the only way the nodules can be removed, one should be very careful when removing nodules because they penetrate deep into the other structures like the intestine. One should remove them in such a way that you don't cause a hole or a fistula inside the intestine. Removal of the nodules here is just to make sex not painful, not to increase fertility. You can see there's a finger. I've got a finger here in the vagina to test how far am I from the vagina, because sometimes you're trying to remove this nodule or to do arteriolysis, which is very hard nodule. You might put a hole in either into the vagina or into the bladder or into the intestine. So you always have a finger, somebody, the assistant with a finger in the vagina to show you how far you are from the vagina so that you can know how far deep you can go. That's why in the management, therefore, you might need two assistants. What are the typical clinical presentation of PID? The typical clinical presentation, which are symptoms and signs, are wide range and non-specific. None of them is specific of PID. They usually worse or soon after menstruation is bilateral lower abdominal pain. Bilateral pain below the umbilicus on the other side, which is dull in nature. It's not sharp. If it's sharp, suspect ectopic or appendix. And fever with a feeling of not doing anything, which is called lassitude. With associated with regular vaginal bleeding, we do endometritis. I said if there's inflammation of the endometrium, there will be regular vaginal bleeding. And this all will be preceded by vaginal discharge, which is pus-like, purulent, copious, and too much, and dull abdominal pain. And on examination on speculum, one could find a discharge either on the cervix or on the part or the posterior fornix, which discharge should do. But by naked eye looking, cannot make a clear diagnosis. White guess might say that if a discharge is whitish and creamy, it's likely to be gonococcus, but there's an error margin in that. If it's greenish, they say it's trichomonas vaginalis, except when it's candida, it will be like cottage cheese. This discharge, which is, if it's trichomonas, because trichomonas are protozoa, they are moving, it will have bubbles inside it, and it will be greenish. But because PID is polymicrobial, in the presence of trichomonas, it doesn't mean there's no gonorrhea. It doesn't mean there's no. How does it present like? Clinical presentation. Clinical presentation of the PID is fever, high fever, abdominal palpation. There will be so much tender that you push up. A woman won't allow it to palpate the tender. On examination, vaginal examination, there will be this foul-smelling discharge, which is pus like purulent. And then the speculum and the vulval examination, external urethral meatus, there will be pus coming out of the Bartholin's lens. That's why one of the commonest causes of Bartholin's lens abscess is the causative organism is gonorrhea. On a bimanual examination, of course, there will be phoneal thickening on the side of the tube because the tube will be thickened. And when you do a speculum, there will be cervix, which is a radius with discharge coming in, like I've shown from the discharge coming from the cervical canal. And the patient might present with the symptoms that might confuse you. If she presents with nausea and vomiting, you might confuse it with appendicitis because appendix also present with nausea and vomiting. But if you present with dyspareunia, you're sure that it's likely appendix will be the second on the list. Sometimes the pelvic peritonitis might spread paracolically along the paracolic gutters to infect the liver, more especially on the right. It causes the liver, adhesions of the liver to other structures in the anterior abdominal wall, a condition which is called Fitzhugh-Curtis syndrome. I'll show you the picture of Fitzhugh-Curtis syndrome later. And this perihepatic adhesion causes dull right upper quadrant pain, which is chronic. This liver involvement is due to transperitoneal or vascular spread of gonorrhea or chlamydia to the liver. If you do a laparoscopy, you find that the liver shouldn't have those catastrical structures. The liver should be free in there. This liver here is adherent to the anterior abdominal wall with these adhesions here. Once you get adhesions up in the liver, you must know there are worse adhesions in the pelvis because the liver will be secondary. For the bacteria to reach up in the liver, it must either spread through the lymphatics or through the blood or spread through the paragolic gutter to reach there. But in acute stage, appendicitis only present with fever, more than 38 degrees, low abdominal tenderness, which might radiate to the leg or the back, and of course, vaginal discharge is pathognomonic with vaginal bleeding. Deep dyspareunia. Dyspareunia is classified into two. There's superficial dyspareunia, which might be due to candida, vulvitis, vaginal stenosis, all those things that affect the vulva and the deep. Deep dyspareunia is when there's deep penetration, which is very tender. And if there's bimanual examination, one moves the cervix, there's cervical motion tenderness or cervical excitation tenderness, as some people call it. It always pathognomonic of PID until proven otherwise, because there are nexa that are involved. And the patient will have, before examination, presented with symptoms of pain in the region of the pelvis. What investigation need to be done? Firstly, because PID is not a killer disease, although it's because morbidity, it doesn't kill people very often unless it causes pelvic abscess or pelvic peritonitis. You must do exclude dangerous things. Firstly, exclude ectopic. Make sure that the woman is not pregnant. Pregnancy test is negative. And exclude appendicitis. Take high vaginal swab of the discharge high in the vagina to identify the organism and send for the laboratory for antibiotic sensitivity. As I said, that there's a lot of different bacteria respond to different antibiotics. So the laboratory will guide you which organism is there and which antibiotic you can use better. Always take midstream urine for microscopic culture and sensitivity, because PID with UTI usually coexist. And don't only do it on the partner, on the female only. On the partner, do it. Not to say that it's from the partner, just because they're having sex together. It means the organism might be both sides. You are not saying the organism came with this one. because the organism might have come from the third party, which third party might come through the wife or the husband. You are not there to judge with that. Just diplomatically tell them that you need to treat you both and examine you both because we want to eradicate the disease in the family. Of course, the full blood count and C-reactive protein is just for monitoring whether the white cell count will go down or C-reactive protein will go down. It's not diagnostic. It's just to monitor the progress of the disease. And I must stress, PID says STI screening, sexual transmitted infection screening, must be done on both partners. This headache in STI treatment, more especially in syndromic treatment of sexually transmitted infection. They say in sexually transmitted infection, you must treat the partner, treat the patient, treat the partner, and partners of the partner, because always there's a third party. Because in a monogamy, you hardly find it. So in your investigation, further you can do ultrasound to exclude things like tubo-ovarian abscess in severe cases. Because in a normal PID, SONA will be normal. It's only when there is a tubo-ovarian mass of tubo-ovarian abscess that you can see it. The presence of fluid in the part of Douglas is not non-specific. You can find fluid in the part of Douglas without PID. Coldocentesis, which is really done now, you aspirate the fluid in the part of Douglas by putting a needle in the posterior fornix and take that fluid for culture. The danger of that is that if that fluid is pathogenic organisms, you might spread the infection. So that's why I say it's not favored by many people. If you've done ultrasound, you can get enough information. And if on coldocentesis, there's more than 30,000 microorganisms per mil, then make a diagnosis of PID. I must say, I'm mentioning it just for academic reasons. Do not do coldocentesis. It's a very old-fashioned aspiration procedure, because the fluid, you can get it through laparoscopy in any way and do bacterial culture of the fluid and antibiotic sensitivity. Laparoscopy is indicated or if the diagnosis is not clear, the woman is not improving, you're not sure whether you are dealing with appendix, you are missing appendix, or you are missing ectopic or ectopic, pregnancy test will be positive. Usually things like appendicitis are the one that will need to laparoscopy to assess as to whether, am I not dealing with a time bomb here? Vaginal swab, must take a swab of any fluid that you find, discharge that found in the vaginal swab. A swab is a medical procedure where a swab is used to collect a sample of fluid in the vagina and the cells in the vagina and to send to the laboratory to test what kind of organism are there. Is either sexually transmitted or not sexually transmitted. Usually, if you do a speculum, you'll see if there's a fluid which is there in the pouch of Douglas, in the posterior fornix, which you can scoop it or either take it with a cotton wool swab. Usually cotton wool swab, it takes better because you just dip it inside there and put it inside the culture medium and transport medium and send it to the laboratory. They'll culture it. Within a week or so, they'll be telling what organism is there, which antibiotic it responds to, unlike to leave it in there. But after taking the swab, clean the vagina thoroughly with sterile saline so that you can clean those and give the antibiotics empirically before you can even know sensitivity. More often, more than 50%, you'll be right if you treat according to the commonest organism in a particular region. That's why I said laparoscopy, it is now considered a gold standard in the management, in that you can obtain the biopsy with it, you can differentiate other conditions, you can obtain the samples of the fluid for microscopic culture sensitivity. And it's not reliable, but since it's not available in everywhere in the third world, much in South Africa, we still resort to clinically treat PID without resort to laparoscopy. So it's only reserved for the severe cases where ectopic and appendicitis need to be excluded, which it shouldn't be like that. In the first world, it's gold standard, because it might help in aspiration of pus fluid from the pouch of Douglas if a patient is not responding to conventional treatment. I want to show you what a normal pelvis looks like. In normal pelvis, there's no fluid in the pouch of Douglas. There are no adhesions in the normal pelvis. There's no pus in the normal pelvis. There's no abnormal masses in the normal pelvis. The fallopian tubes are free and moving and excellent fimbriae. This is the typical picture of a normal pelvis. If you do laparoscopic appearance of dual laparoscopy, the ovaries are moving freely. These are tubes that freely. There's no fluid in the pouch of Douglas. This is typically a normal pelvis. I'm showing you this normal pelvis so that when you see abnormal pelvis, you can recognize it, that it differs from that other normal pelvis. Like, for example, you look at this pelvis, which has got, once the uterus goes up, you find adhesions. I'll soon remove the intestines from here. Once I remove that intestine, you can see that the two pelvis are quite different. This one has got adhesions in there. You can hardly see the pouch of Douglas. The omentum is adherent to the tube there. You can remove it. While the normal pelvis, there's no such things as adhesions in there. The tubes are mobile and the intestine are adherent. In the abnormal pelvis, the intestine are adherent to the pouch of Douglas there. You can hardly see. That's why abnormal pelvis is found mostly in patients who present with inability to conceive, infertility. The severity of PID, you stage it differently. Some people say mild, moderate, and severe. But the PID, usually academically for medical students, the mild one, the tubes will be swollen and inflamed. There will be no adhesions, no peritonism on examination. Cervical excitation tenderness, also present, will be minimum. The mild one. In a severe one, there will be adhesions, the tubo-ovarian masses. Tuberculous infection, if you find TB, genital TB, is not regarded as part of PID. PID is only involved if there is an accepting infection from other bacteria except TB, because TB is not an ascending infection. It's a systemic infection. It can come from TB of the lungs, TB of the bone, TB everywhere. And it can go up to the genitals, in the tubes, in the ovaries, and the uterus. If you find TB, it's not part of PID. Tuberculosis infection is not defined as PID, as PID only involves ascending infection from below. TB is a systemic disease, but academically the staging, we say stage 1, if we want to stage 1, 2, 3, salpingitis without peritonism. These women will usually present with no symptoms. You will find it incidentally for a woman who came for a pap smear or just for routine checkup. If there is peritonism, peritoneal inflammation, is stage 2. And if the tubes are blocked or the tubo-ovarian complex, a mass, then it's stage 3. If there's an abscess, which is ruptured, which is a medical emergency, then it's the last stage, is stage 3. That's a severe form of PID. Like I want to show you, this is an inflamed tube. The fimbria are fimosed. This is tuberculous, and there's some caseous nodules on the right tube there. The left tube causes adhesions, which are very hard adhesions, hard to remove. That's the tuberculosis. But the mere diagnosis you can make by taking a biopsy. By just look, you can suspect. But majority of tuberculosis, they cause hydrosalpinx, like the hydrosalpinx that they show in there. But if it's TB, it's not PID. So always make TB. If a patient has got, a patient with genital TB will always more often have a history of pulmonary TB. Unless some people might not know that they've got TB, but it usually comes from somewhere, when the commonest is pulmonary. So let's look at the laparoscopic finding of different grades of PID. Mild PID, I said the tubes are edematous, they're reddish in color, but there's no pus, there's no purulent exudate. And the moderate one, the purulent exudate come from the fimbrial end, which might irritate the pelvic peritoneum, but doesn't compass, but is likely to form adhesion of the tube and the tube might not be freely mobile. In severe one, of course, there will be hydrosalpinx or biosalpinx, either fluid in the tube or pus in the tube, or you can have a tubo-ovarian complex. Once you have got violence 3-like adhesion in the pelvis or around the liver, this condition which is called Pathogenesis syndrome, suspect Neisseria gonorrhea or chlamydia as a causative agent. Those are the only 2 organisms that will cause tubo-ovarian Pathogenesis syndrome. This is a mild PID. Mild. The tubes are mobile. There is serous fluid in there. There's minimal addition of omentum to the tubes, but there's no tubo-ovarian complex. And then thereafter, you can have moderate adhesion. Adhesions are worse than mild one. The tubes might be blocked or might not be blocked. They are tortuous. There will be adhesions bilaterally. The tubes will be swollen, adherent to the ovary, and the omentum, like you see here, is worse than this one is worse than the previous one. This one is mild, this is moderate. We'll go to the worst one now. So depending on what you find, you must grade it whether it's mild, moderate, or worse. That will prognosticate to the patient whether is there any chance that she'll have a baby or she will not have a baby. What are the chances of me treating it successfully or not? The worst one, there will be severe adhesions, which I said adhesions are not well supplied with blood. So there's poor penetration of antibiotics. So if whenever you find adhesions, remove them, separate them so that they can be good blood flow. When you give systemic antibiotics, they can penetrate to far areas and penetrate deep away. Like this one, you see there's abscess coming out of the tube there, which will need to be thoroughly drained so that it shouldn't. Look at the adhesions. This adhesions that the tube is adherent to the uterus here and is swollen. But surprise, if the tube is open, don't ever write the patient down out, because if the tube is open, she might still surprise you and have a baby, but the chances of having a baby with a pelvis with severe adhesions like this, the tubes being adherent to the omentum, you see with adhesiolysis like that one, it's trying to clear the pouch of Douglas. Pouch of Douglas, that area below the uterus, we try to clear it laparoscopically. I find it laparoscopically being better than laparotomy, because there you've got a 2-dimensional view with added advantage of magnification. This is the fallopian tube adherent to the omentum, which with good dissection, you can leave that tube. That tube doesn't look very excellent, but if you test it, become positive, with good antibiotic treatment, it might just conceive. Those fimbria recover very well. You know, some human tissues are very forgiving. This is the left tube, which is also adherent to the omentum. These are severe. This is what is a severe PID. The tube doesn't seem to have good fimbria here, but I haven't tested for the tubal patents, which I should after that. And then if they are patent, you don't write that patient off. She might have babies thereafter, but the fact that they've been damaged by the adhesions increases the chances that she might be infertile. But you cannot just say infertile before you test the tubal patency and severity of disease. What I'm saying is that it doesn't mean every severe infection will lead to infertility. Some people will be infertile. Even those patients with a liver involvement, some of them has made children. This is, again, the picture of severe PID with liver involvement with the condition called Pathogenesis syndrome, which is perihepatic adhesion, which is caused by Neisseria gonorrhea or chlamydia, which I said it spread either through the lymphatics or through the blood, or it can spread through the paragolic gutter translomically. What are the differential diagnoses of PID? Differential diagnosis, what do you mean? Differential diagnoses are conditions that may be confused with PID. The clinical signs are the same. You see, it's either it's PID or it's this. They present more or less the same. There are two main ones. Appendix can be confused with PID. So if you don't have appendix at the end of your head, you don't take good history and examine very well, you might miss appendix infection and think it's PID, and that would be fatal. And ectopic pregnancy are the two main differential diagnoses. That before you treat the PID, make sure that you're not dealing with these two dangerous conditions, because those two dangerous conditions are emergency. Torsion of ovarian cyst or rupture cyst is one of the differential diagnoses, but that can be seen very well through ultrasound. Endometriosis also, it cannot be acute. It will have been there for a long time with the menstrual pain, which are many years. Diverticulitis will have other bowel symptoms. Urinary tract infection, of course, it can also be that if it's severe, but the fever will show you what it is. The only thing that I usually tell the patient, that I tell even students that, look, you must never miss an ectopic pregnancy and think it's PID. Any patient with severe pain, which has not been there, whether I've got beta HCG positive or negative, at the end of the day, exclude ectopic pregnancy, because ectopic pregnancy, if it ruptured, it can bleed and be fatal. And the ectopic pregnancy, there's only one treatment of ectopic pregnancy, whether ruptured or not. Majority of us present ruptured is removal of the tube. Just go and remove the tube. And ectopic pregnancy comes as a sequelae, aftermath of PID. PID damaged the tube. The fertilized egg cannot be moved to the uterus, and the fertilized egg implant inside the tube, and that's causing ectopic pregnancy. So that's why I said a person with ectopic pregnancy with PID has got more chances of developing ectopic pregnancy than a person without pelvic inflammatory disease. This is another patient with the with a clinical signs that came with clinical signs of pelvic inflammatory disease, but on examination and investigation, we discovered that she has got ectopic pregnancy, which was treated successfully. Should you have missed this because she's bleeding inside, we might have lost this patient. What are the complications of PID? There are immediate complications and late complication. Immediate complications are pelvic peritonitis or generalized peritonitis, if it's spread generally, and cause septicemia. Septicemia means infection goes inside the blood, and the blood moves all over the body. It can cause arthritis, goes to the joint. It can go to the heart and cause myocarditis. It can go to the meninges and cause the brain, can spread all over the body. So those are the immediate complication if not treated very well. The late complication, of course, is even if after healing, after treatment, you will have chronic inflammation with chronic adhesion, chronic pelvic pain, which even after treatment, you still have dyspareunia, or it can pass in the tube or water in the tube with hydrosalpinx, which I said are the commonest cause of infertility. And if it causes abscess between the tube and the ovary, that complex tube-ovarian abscess, it's a late complication, which the treatment is just removal of the tube-ovarian abscess, which in that case, because if you remove the tube and the ovary, you are reducing the fertility and it decreases the chance of ectopic pregnancy. I must stress that if it happens in young children, the result will be found when she's in the childbearing age. And the more the number of PID a young girl has, the more the chance that she won't be able to bear children. So warn children about PID, because PID as a cause of infertility is a cause of trauma to the couple and to the baby. There's the woman. There's nothing that saddens a woman. It's my personal experience, like telling a woman that your tube has been damaged by PID for so long that there's nothing that they can do, and the couple is poor, they can't afford PID. That woman just cry, and that cry won't help anything. But human nature dictates that we can't say, these are the results of your previous sexual habits, which you should tell that bad sexual habits will result in permanent tubal damage. And when the truth be told, then the whole pleasure in the house is done. Because if a couple is married and discover that the woman, there's no way she can bear children, the poor man is already married. Now he is standing. Do I stick to this woman or do I not stick to this woman? The woman think, are they going to dump me or they're not going to dump me? Then you bring psychology. Psychology is not going to bring the child. Adoption is not so easy. They look at the financial situation of the couple. In poor couple, the results of PID are devastating. And as in the introduction, the poor people are the ones that have got more PID because they're the ones that engage into what I defined as commercial sex. So there's nothing that pleases a couple than to do a pregnancy test in a woman who said, I've missed a period, and they go and buy a home pregnancy test. It shows 2 lines. They are very happy. Every man wants to be once in his lifetime, be proud to see his abdomen, the wife getting disfigured, and he is impressed by disfigurement of his own wife, which is a pleasant disfigurement with you touching a pregnant woman, rather than to complain of pain always during and after pain and infertility. So the late complication like dyspareunia, in addition, and retroversion of the uterus, is the one that causes dyspareunia. And formation of adhesion and adhesions and hydrosalpingo and tubal ovarian abscess should be avoided by the condition that I've said, are like abstinence, condom, if they are usage. You won't have, if you don't, as I said in the beginning, the chances of ectopic pregnancy will be less, and the chances of undergoing extensive investigation and treatment with additional in trying to normalize the pelvic, which has been very much damaged, with very little chance, prospect of success. If the pelvis is damaged like this during infertility, we try to do additional and try to normalize the pelvic anatomy, but we can't guarantee success. Sometimes, like on the right, we've got a tubal ovarian complex here. The only treatment of tubal ovarian abscess is tie it with an endoloop and remove it. While on the other hand, if a woman is lucky, she's got to some peritubal adhesions around the ovaries, you can tie them with a laparoscopic scissor. With luck, the patient will have treatment. So, in summary, the goal of treatment of infertility, there's only one to go. There are 3 goals of treatment: to eradicate the infection completely, and to prevent infertility and the late sequelae of infection of PID that I've said previously, like tubal ovarian complex and infertility, and prevent reinfection. How to prevent reinfection? Because education is part of treatment. By educating the patient on the safe sex, sexual habits, that people should have safe sex. But you don't only educate, I don't mean only the woman, even the man. And if they are educable, I wonder whether people are educable, can receive education. But because treatment usually starts with intravenous treatment, antibiotics. Sometimes in a mild case, you can only give tablets as outpatient treatment, and it can remove whatever amount of pain is there. You rarely find ectopic pregnancy in pregnancy. With my patient, I treat them with visuals. I've got a model like this that I show them what the organism, when they come from the vagina through the cervix, how they damage the tube. And of course, I show them the visuals of the tubes that are damaged by PID. Like you look at this one. This is the ruptured ectopic from patient with PID that I usually show patient. This is what's going to happen to you if you Sorry, this is the slide that I used in the International Congress when I was presenting in Germany. So I put Oliver Mtukudzi on top, trying to boast to the Germans that in Africa I've got Oliver. So I couldn't talk with Oliver Mtukudzi talking. That's what I show the patients what happens, what will happen with PID. And I also show some of the things that I show are things like this, that patients with adhesions, how adhesiolysis sometimes can be helpful in reducing pain, but not in restoring fertility, on restoring normal tubal anatomy. In this case, this woman presents with hydrosalpinx, deep dyspareunia, chronic pelvic pain, and on laparoscopy you find adhesions like this. All you can do is remove that tube from the Port of Douglas in the patient whose uterus is retroverted like that, and make the patient antivert the uterus by the process called ventral suspension and leave it like that. But the tube like that is totally damaged if you compare to that I shown you the normal pelvis. You can see that this one has got a lot of adhesions, but you can remove that tube there and the patient will have less pain. The treatment, antibiotic are usually prescribed, even early before microbiology results come, depending on the experience. Infection as usually polymicrobial. The combination of antibiotic broad spectrum will be given different type of antibiotics because different organisms respond to different types of antibiotics. Some respond to the quinolones, some respond to the penicillin, the cephalosporins, the flagell group. So you'll be given a battery of antibiotics. The average treatment is 14 days or mixed. Even if admitted and given intravenous treatment, then followed by the treatment which is oral. On the average, it's about 14 days. And during that 14 days, you advise the couple not to engage into sexual activity because engaging in sexual activity might just mean reinfection. So indication for admission to the hospital as per Center for Disease Control in 2006, CDC said that if patient has got severe illness like described in the tubo-ovarian abscess, ruptured tubo-ovarian abscess, and she would vomiting and temperature over 38, we must admit. If we suspect tubo-ovarian abscess, admit to the hospital. If uncertain about the diagnosis, you're not sure whether you are dealing with appendix or you're dealing with other surgical images like ectopic or any other colonic emergency, admit and do investigation, including laparoscopy, to make the right diagnosis. If a patient is being given antibiotic treatment for 2 days, for 48 hours, then no response, he comes back to you, admit. If the patient cannot tolerate antibiotics, and for some reason the compliance is poor, because patients just come and say, "This my antibiotics make me vomit. I didn't try about it." Then admit that patient. And all HIV positive patients, because all bacterial infection in HIV positive patients become fulminant, must be admitted to the hospital and treated. And if there's pregnancy in PID, I must say this, PID never happened in a person who's pregnant. You can't be pregnant and have PID thereafter. But you can have PID while you have PID and fall pregnant. That way you'll have PID coexisting with pregnancy because pregnancy found PID there. But if you are pregnant first, you can't have PID. Those patients must be admitted for at least a minimum of 7 days and be given antibiotics intravenously. And inpatient therapy inside the hospital, patient must be bedridden. It can even be catheterized. He must go to the toilet so that there must be good perfusion of the organs and good distribution of the drug. And it must be given good fluid to correct the acidosis that might be caused by inflammation. And for, as I said, up to 7 days of intravenous antibiotics until you measure the progress by temperature coming down. If you examine it daily, pelvic tendons are getting better, and blood count, which I said you take full blood count for monitoring, the white cell count will normalize or come down while the patient is there. You find that when you are admitted, day or a day after 2-3 days, they'll take blood to go and check for the white cell counts, whether the indices are coming down, they're not coming down, in hospital, inside. So treatment of in which conditions is surgery necessary? If there's pelvic abscess, operate, surgery. If there's tubo-ovarian abscess, no need for antibiotics, only surgery. No response to treatment after 72 hours, surgery. Then surgery, I advocate that in the absence of abscess, always do laparotomy, no place for laparoscopy, because laparotomy you can wash all over, even the paragolic gutter, the lesser sac and the greater sac and everywhere. But laparoscopy, you'll have limited access to other areas that you cannot get through laparoscopy. So prevention of reinfection is through education. Like this webinar is in education, it's prevention of education, and know the potential dangers of PID. Warn the patient against dangers of multiple sexual partners, both men and women. The dangers of multiple partners. We have got a tendency of glorifying men who have got multiple partners. Is an elbow, but if a woman has got multiple partners, then the way the names are derogatory. They are both bad in male and women. Multiple sexual partners are not. It's not a good habit. In South Africa, after 1994, we were anti-education. They legalized polygamy, I've said that. And they are contemplating legalizing polyandry. Yeah, we've got mad people in the parliament. I always said long ago that before we choose those people to go and make rules for us, we must give them the aptitude test. Some of those people, I don't think IQs are very high. You can't think about polyandry. South Africa, they legalize sex workers, prostitution. If they cannot create economy, then they say women must make money through sex. We're trying to educate, but we've got a fertile ground constitution, which is the West Constitution, of course. You say is the best. Other countries say it's the West, which is a fertile ground for PID and moral degeneration. Of course, in prevention, trace the sexual partners if you can. If you can't, hard luck, and treat them. Some women will tell them, my partner is another one. I've got another partner who is the partner in the armpit, then you give a treatment, say, because you can't stop the trace the partner or the partner also, and stop commercialization of sex. I don't know. I don't know how to stop it, but I just stop it. Maybe stop it by improving the economy, because 350s did not. SRD, the 350 that they give to children, even the child grant did not stop the commercialization of sex, such that you find but stop abusing sex workers. Sex work is also work, which means I work sex, which is bad. I always pass where there are trucks standing. There are always thin girls coming there. We don't know what attracts them. It's like flies. When you put milk there, flies just come. And they're always thin. And if they are thin like this, well, it can't be so thin. They are now finding a girl with good BMI figures going to the track there. There are always these thin ones who are sick. They're going to get PID, or they always have PID. So as I said, it's not common in pregnancy. It only if it coincides with pregnancy, it means the patient had PID and then fall pregnant while having PID. But once you can be pregnant, there's mucus plug that plugs the cervix there, which is called an operculum. There will not be any ascending infection because there will be a plug there. And the fetal membranes also seals that area. There won't be any ascending infection. So if present infection, it means infection antecedent conception. So it must say PID never found in pregnancy. It can be. Then in the follow-up, actually, patients should be re-examined after discharge for 7 days and try to see as well there is persistence of infection or recurrence, because there's a difference between persistent. Persistent is when you treat infection, you don't treat completely. Once you stop treatment, it comes back again. That infection persists. But recurrence is infection that was completely treated and the woman goes and take another PID somewhere. And then if necessary, repeat the culture or cervical swab depending on the status of the money. Most medical aid will not allow that for 3 consecutive months to make sure that everything is purely treated. But because you're controlled by medical aid, they'll only allow 1 culture. But if money is there, ideally, you should do it like that. Until both the woman and the sexual partner are completely treated, no sexual intercourse, which is hard. So what's going to happen? The woman and man will go and get another infection from somewhere. Advise them to use condom. I usually advise them, don't stop them altogether, because if you stop them altogether, you're inviting trouble. To use condom. The only definite and equivocal proof of successful treatment of salpingitis, if the woman thereafter can fall pregnant, you show it is. Because, you know, a healthy sexual habits usually will lead to a healthy social life, even at home and outside, and a healthy resultant family. It's so good that every woman wants to get married and have a baby and live a nice life. And it's